Hello everyone. Can you see me or hear me okay? Thank you. Thank you. Okay, we'll just wait for a few more minutes to let more people join in and we'll make a start, okay? Right, okay, we'll make a start now. Let me just share my slides. Just if you can see my slides, just pop something in the chat, please. Thank you. Thank you, Sana. Okay, hi everyone. Welcome back or welcome to the finals teaching series. Today is our third session on respiratory, and we are going to cover lung cancer and metastatic disease. Lung cancer is quite an interesting cancer, quite academic, lots of different types of complications. So hopefully it will be interesting today and you'll take lots of it.
Oh, sorry.
Okay, so some of the key learning objectives today would be identifying the common symptoms of lung cancer and identifying the key risk factors. We'll go over the NICE guidance as well for referral for suspected lung cancer and the role of primary care as well. Histology is very important for lung cancer, so we'll go over the different histological types like small cell lung cancer and non-small cell, their unique features as well, and some of the paraneoplastic syndromes and some of the complications that can happen with specific types of lung cancer. In terms of the diagnostics as well, we'll go over the imaging as well as the types of biopsies that we can use. We'll go over the management and palliative and how to support patients with counseling as well. Right, okay. Sorry. We've got Daniel from BMA to give a brief talk about BMA. Just 1 second.
Okay, cool. I'll be super duper quick. I'll just share the entire screen. I think it's the easiest thing to do. So yeah, sorry to interrupt. But yeah, I'll be super duper quick. It's obviously a pretty important time to join the BMA, to get involved for a few things that I'll talk about in a minute. Obviously, there's been massive, well, I want to say massive pay increase over the last 2 years that we've got. So that's obviously going to affect you guys going into F1. So yeah, 22% of the pay that you'll be getting is what we've negotiated over the last 2 years. So we need you guys coming in to be as involved, as vocal as the years before you and your colleagues, so that we can keep pushing for more, basically. If you're not already a BMA member, take advantage of what's on the screen. £10 Amazon voucher if you join today using that link. Drop me an email after you've done it, and I'll get the voucher sent over to you. We don't usually give away anything free for joining. It's only £3.50 a month, so the Amazon voucher basically covers you till like May, June. So yeah, you're basically getting free membership till May, June with that money you're getting back. So make the most of that, is what I'd say, because there's things coming down the track in the next few weeks. God, I want to do this as quickly as possible, not to disturb you much more. But yeah, very important what we're doing. I'd say we're your trade union, so sometimes we get a bit of confusion with companies like MDU and MPS. We don't do the same things. Then we do something the opposite end of the scale. So basically, they're dealing with sort of the clinical insurance side of things. So if you had to accidentally cut a patient or something like that, you would go to them. Us as the BMA or your union, so it's everything sort of pay, contracts, non-clinical, that kind of thing is where we help you. We can help on an individual basis, so it's not just national stuff that we do. And obviously, if you're a group of F1s going through the same thing as well, we can help in that sense. So local, national, individual is the way to look at it. So we can help in those sort of free ways. And then obviously there's loads of other stuff like the BMJ learning tools and all that kind of thing as well. We only represent doctors and med students, so that's probably why we're the strongest trade union in the country. I think it's fair to say at the moment with the results we got. So yeah, it would only be for you guys, and our sole focus will be on sort of you as doctors. I'm sure everyone's done MLA at this point. Possibly some people are still doing it. I think George is still doing it in London. But yeah, if you've still got the MLA coming up, we've got a question bank on BMJ on examination, which is free as part of membership. 2,000 questions on there. It comes as a mobile app as well. You can also use it as offline access. And if you are, you can do it sort of like social learning, so you can sort of do sort of things together as like a group. So it's not just you sort of learning by yourself, like things like interactive quizzes and whatnot. As a membership as well, in final year, you get the BMJ subscription for free. So through the post, you'll get the doctor's version of the BMJ, not the student version. So that's delivered fortnightly. We moved it recently from weekly to fortnightly, and we just made it bigger. So yeah, if you're already a member, you're not getting that. All you have to do is get in touch, say, look, I'm final year, and I'd like to be getting that subscription. It's free. Cool. Clinical Key, probably got access to Clinical Key through your med schools as well. But Clinical Key, you've got full access to that with no paywall, so there's no sort of blocked parts of it as maybe you might have with the med school stuff. So full access to Clinical Key. We've got a Specialty Explorer tool, essentially a psychometric test. It takes about 20 minutes to complete. It'll ask all sorts of work-life balance questions, and then at the end, it'll give you a breakdown of what specialties will suit you according to the answer you've given. Pretty good to do it now. maybe when you start F1 as well. And then just as by the time you get to your specialty, you've got a bit more of an informed choice. It always throws up things that you might not have thought would suit you, but do. I know there's lots of learning going on at the moment, but yeah, we've got some sort of clinical and non-clinical stuff that you might want to look at ahead of becoming an F1, which might be helpful as well. So, like I said, all the BMJ learning tools are free to you as part of that £3.50 a month subscription, as well as everything else that we do and everything else you get. These are the kinds of issues, or kind of questions that we get sort of leading up to F1 and sort of in F1. So BMA membership is not something that only starts sort of when you become F1, like the indemnity stuff. BMA is right now, so it's stuff that you can be using right now. So yeah, hopefully more reason to join. So yeah, that's some of the questions that we get. Money's obviously a big part of what we do. Last year we got about £2 million back for members who oftentimes just send in the pay slips and the contracts and whatnot speculatively, but we negotiate those things so we know what should be in them, what shouldn't be in them. Any issues around leave and that kind of thing, so we can help with. Right, I'm getting there. Sorry, but this is important. F1 pay obviously has gone up nearly 25% in the last 2 years. So you guys are obviously going to be the main benefactors of that starting this year. Sort of the first sort of untouched group really. Last year we were still fighting for it. The back pay was only paid sort of November, December, but you will go straight on to this. So that is what's on the screen is sort of the basic pay. So that's before any sort of uplifts or not that's great if you are in London waiting and that kind of thing. So yeah, 25% increase pretty much is where we've got to, and you can see across the board as well that it's gone up around about on average 22% for all grades, resident doctor grades. Sorry. So this is where we are now. We're actually getting ready to ballot once again. It's sort of going on behind the scenes. I don't know if you've seen, but the government recommended to the DDRB 2.8% uplift for doctors this year. That obviously falls way short of pay restoration, which is still our ultimate goal, which we see as another sort of 20% off. So we are preparing now for possible, probably more ballots once the DDRB say, yeah, we agree with that, which basically they always do. So yeah, this is coming down the track. This is going to affect you guys. If we do get a mandate, it's obviously lasts 6 months, and that obviously goes into when you guys are F1s. So you guys will have your say in any offers that we get, in any action that we do or don't take. So being a membership is critical, especially for you guys coming in and being as strong as everyone else. So watch this space on that. But obviously, if you're not a membership, you can't do anything, and we've only been this strong because everyone's sort of involved. Yeah, we obviously want about 28% increase again, but how realistic that is, we'll see. If we get any kind of concrete offers that we think is worth putting out, thinking off the top of my head of it, so like we get 10%, that will be put to you if you're a membership to vote on, as we've done with the recent offers back at the end of last year, which was voted through. So yeah, that's it. I'm sorry to have interrupted. I'm sorry that I only got the link sort of in the last hour to come along and speak to you. So I'm sorry. Join, be part of what's going on. It's starting up again, and you guys will have your say in it. Whether you want to strike or not, just have your say. Be part of things. It's £3.50 a month, and that goes until October. Then F1 membership is about £8 after tax relief, so it's still not that much. And obviously, if you join today, you get a £10 Amazon voucher. So that pays off £3.50 in a few months. Take advantage of that because we don't give Amazon vouchers and stuff like that on the website. That's it. Cool. I'm so sorry again to have come in a bit late, but thanks for letting me speak. There I am. Sorry, I'll let you crack on with the rest of the session. Thanks, everybody.
No, thank you very much. Right, okay. I think my network is not great. So if at any point I'm not audible, please let me know, all right? Let me just bring up the presentation again. Okay, so lung cancer is the third most common cancer in the UK after breast and prostate. It's the most common cancers in lots of other parts of the world as well. And when we say lung cancer, we mean that tumors, the primary tumors, originate in the lung parenchyma or the bronchi. Okay, so let's go to the next slide. So histological classification of lung cancer is very important. So we've got small cell carcinoma, which is about 20% of all of the lung cancers. And these are essentially smaller cells that grow quite rapidly. So these cancers are associated with early extensive disease. And after that, we've got non-small cell lung cancer that are relatively more common. They're about 80% of all of lung cancers. And then we've got adenocarcinoma, squamous cell carcinoma, as well as large cell carcinoma. So they are, as the name says, it's not small, so it's bigger in size, and they divide relatively slower compared to the small cell lung cancer. So in terms of your symptoms and signs, as well as risk factors, so if we look at the respiratory side of things, one of the most common initial presenting complaint might be cough, particularly if it's a long history of cough. So if it's been ongoing for a few weeks or maybe months, it might be that patients have been treated with multiple antibiotics for suspected chest infections, and it's not doing anything for them. Hemoptysis is a very common sign as well, and it's clinically very important, and it's one of the red flags that we worry about with lung cancers. You get shortness of breath, chest pain, and I put in bracket unexplained, so it's not really explained by any other pathology like MI or your musculoskeletal pain. So that is something that's worth looking into as well. And as with any cancers, we get our constitutional symptoms that include fatigue, unexplained loss of appetite, as well as some weight loss as well. In terms of your examination findings, so you can see some clubbing. That's common with lots of different conditions, but lung cancer is one of them. You can have some enlarged lymph nodes, and the ones to look out for lung cancer would be supraclavicular or cervical. Risk factors, so smoking, not surprisingly, is the biggest risk factor. About 80% of lung cancers are thought to be caused due to smoking, which is essentially preventable largely. So lots of smoking cessation advice and preventing patients from smoking is important. Asbestos exposure is, again, a risk factor for some of the lung cancers, so occupational history is important in this particular scenario. Metal exposure as well. Pulmonary fibrosis is an independent risk factor of lung cancers, and there can be certain genetic mutations that pass down through families as well. In terms of your basic investigations in the community, so if you've got patients with thrombocytosis or maybe pleural effusion or a lung mass on chest x-ray, then those are things that you might want to look into further. Right, so we'll start with case number 1. So we've got a 70-year-old man who presents to his GP with 6-week history of worsening shortness of breath. He's also very lethargic, and he's noticed some weight loss. His past medical history includes COPD, hypertension, and he's an ex-smoker. The clinical examination is unremarkable, and we've got some blood results here, as well as his chest x-ray shows some hyperinflated lung fields, but there is a normal heart size. So I'll just put up a poll here and let me know what you think. Okay, so everyone's gone for urgent referral to the chest clinic, and that's the right answer. So essentially, we've got a patient who's got lots of respiratory signs, and even though the chest x-ray is normal, he's got lots of risk factors for lung cancer. So you're very right in referring him to the chest clinic. So just a brief overview on the guidelines, and this is the NICE guidance for suspected lung cancer. So the first one says that refer patients using the suspected cancer pathway. So this is usually an appointment within 2 weeks for lung cancer if they have chest x-ray findings that suggest lung cancer. So that might be a mass in the lung, or if they're aged over 40 with unexplained hemoptysis. So in that question, we know that that patient had a normal chest x-ray, but they had lots of risk factors for lung cancer, and a chest x-ray doesn't always show a lung mass, so there can be lots of false negatives. So a referral to the chest clinic would be appropriate. Lung cancer is not the only condition that causes hemoptysis. So what are some of the other causes of hemoptysis? If you just put that down in the chat. And again, it's a safe space. No one is really recording what anyone's answering, so feel free to pop in any questions or any thoughts you have as well. Yeah, lots of good ideas. Yeah, esophagitis, GI bleed, COPD. Yeah, bronchiectasis, esophageal varices. Yeah, lots of good ideas. Okay, yes. So lots of other conditions can cause it as well. We've covered most of them. Some of the other ones to think of would be maybe a PE, lung abscesses, cystic fibrosis. If people have underlying bleeding disorders as well, that makes them susceptible to more bleeding, then they can present with hemoptysis. Mallory Weiss-Tier, yeah. Pneumonia, yeah, in very severe cases, if they are coughing a lot, that might cause straining and some amount of hemoptysis. So yeah, lots of good ideas. Okay, so that was the first referral criteria. And the second one is you want to offer an urgent chest x-ray within 2 weeks to assess for lung cancer in people who are aged over 40 and they have 2 or more of the following unexplained symptoms. So things like cough, fatigue, shortness of breath, chest pain, weight loss, or appetite loss. I can appreciate that these symptoms can often be a bit non-specific and vague. So it's very important to look at the clinical picture and the risk factors and the ongoing full clinical history as well. If people are smokers or if they've smoked in the past, then you only need one of the following to be able to get that urgent 2-week chest x-ray. The third one is you might want to consider an urgent chest x-ray for people aged over 40 if they have any of the following. So persistent or recurrent chest infection, as I mentioned earlier, it might be a patient that you've treated over months and they've got repeated courses of antibiotics for a suspected chest infection, which is not recovering. So you might want to do an urgent chest x-ray and see whether there is something suggestive of lung cancer. With patients who have pneumonia and they've got high risk factors, you might remember that we do a chest x-ray 6 weeks after the initial one to check for any residual consolidation, because that can indicate a hidden cancer as well. Finger clubbing, again, this is a very important clinical sign of lung cancer, and if you see it in clinical practice or in your OSCEs, you want to keep lung cancer at the back of your mind as well. Supraclavicular lymphadenopathy or persistent cervical enlarged lymph nodes, chest signs consistent with lung cancer or thrombocytosis. Lots of cancers release some procoagulants as well. Lung cancer is one of those. So if you see a high platelet count, you want to think about that. Okay, so next we've got case number 2. We've got a 64-year-old male who presents with a 3-month history of progressive muscle weakness, especially in the proximal muscles. He has a history of smoking and recently developed persistent cough and weight loss. Chest X-ray, a CT chest shows central lung mass, and a biopsy confirms small cell lung cancer. The patient also complains of dry mouth, blurred vision, and orthostatic hypotension. Which of the following is the most likely paraneoplastic syndrome causing his symptoms? So I'll set up a poll now. So essentially, in this case, we've got the diagnosis and we need to identify which of the following syndromes is causing these symptoms. We've got 3 responses so far. I'll just wait for a few more. And if people are answering, feel free to put in your reasoning as well as to why you think your answer is the right one. Okay, so in the interest of time, I'll just move on to the next slide. So it is Lambert-Eaton myasthenic syndrome. And essentially, the clues in this question are he's got proximal muscle weakness. We know that he's got a smoking history, and we have a confirmed diagnosis of small cell lung cancer. And he's also got some autonomic features like dry mouth, blurred vision, and orthostatic hypotension. So that is suggestive of Lambert-Eaton myasthenic syndrome. And we'll discuss all the paraneoplastic syndromes in the next slide. Just about hypercalcemia of malignancy. So small cell lung cancer is associated with lots of paraneoplastic syndromes. Hypercalcemia is one of the ones that it's not associated with. So it's more associated with squamous cell lung cancer. And we'll go into that in detail in the next few slides. With hypercalcemia, you would also expect your typical stones, bones, groans. You might expect maybe some renal colic or a different colic, maybe abdominal pain or confusion. So there's nothing in the history that's suggestive of that. It won't be Cushing syndrome. So with Cushing's, we would expect maybe some Cushingoid features in the face. So maybe a moon-like face or hypertension. There's nothing in the history that's suggestive of that. With cerebellar degeneration, you would expect maybe some coordination problems. And with SIADH, it's more of non-specific, low sodium. So that can be confusion, it can be headaches. So there's nothing in the history suggestive of that. So it's Lambert-Eaton myasthenic syndrome. So just a brief overview on small cell lung cancer. So these are neuroendocrine tumors and they release hormones. So the small cell lung cancers are most commonly associated with paraneoplastic syndromes. It's more centrally located, and we can see that from the picture here. It's the blue star near the bronchus. And these are associated with rapid growth, early mets, and usually carry a poor prognosis. So majority of the patients have extensive disease at the time of presentation. So in terms of the Paris neoplastic syndrome, so there are four main ones to remember. So the first one is ectopic Cushing syndrome. So essentially the tumor is releasing ACTH, and that increases cortisol. Normally, ACTH is released by the pituitary. So if we do the dexamethasone suppression tests, it would not be suppressed on both low and high dose if it's caused due to an ectopic cause, which is small cell lung cancer. Some of the other things some of the other paraneoplastic features would be hyponatremia caused due to syndrome of inappropriate antidiuretic hormone. So ADH is antidiuretic hormone, and essentially it does what it says. So antidiuretic, so it preserves the water in the body, which causes low sodium. So any symptoms of low sodium include fatigue, general aches, confusion, maybe reduced GCS as well. And with hyponatremia, you want to slowly correct it, because if we treat it very aggressively, it can cause damage in the myelin sheath. So it can cause cerebral pontine myelinosis. So we want to correct it relatively slowly. Lambert-Eaton myasthenic syndrome is a disorder of the neuromuscular junction. So essentially, the tumor is causing some antibodies against the voltage-gated calcium channels, which causes impaired release of acetylcholine, and this causes weakness in the arms. It can cause weakness in the eyes as well. So it can cause drooping of the eyelid, slurred speech, swallowing issues. And one of the features with this type of weakness is improves temporarily after exercise. And the way to differentiate Lambert-Eaton myasthenic from your regular myasthenia gravis would be that these can have autonomic features like dry mouth, orthostatic hypotension, maybe urinary retention as well. The fourth and the last paraneoplastic syndrome is limbic encephalitis, and this is also when the immune system creates antibodies that attack the brain tissues, specifically the limbic system, and that can cause short-term memory problems, confusion, seizures, hallucination. One of the antibodies that's associated with this is anti-HU antibodies, so that's something to remember as well for your exams. Okay, so let's go to case number 3. We've got a 68-year-old male who presented with a 40-pack-year smoking history, who presented to his GP with progressive shortness of breath, weight loss, bone pain, and he also reports increased fatigue and recent history of new-onset confusion. On clinical examination, he has clubbing and tenderness over the distal bones. A CT reveals squamous cell carcinoma, and we've got the following blood results. Which of the following is most likely the cause of his hypercalcemia? Okay, so we've got some divided answers. If you feel happy to just pop in the reasoning as well, that would be very useful. Okay. So the correct answer here is B, parathyroid hormone-related peptide secretion. And essentially, I'll go over why the other answers are not correct in this instance, but thank you. So we've got a person who's got squamous cell lung cancer, and if you remember one paraneoplastic feature of squamous cell, it is that it releases this hormone-related peptide, and that causes hypercalcemia. So that is, if you want to remember one thing about squamous cell cancer, that would be the thing to remember. It's very commonly tested in exams. So why is it not the other answers? So bone metastasis. So there's nothing in the history that's suggestive of a pathological fracture or and the fact that he has squamous cell cancer is more in keeping with parathyroid hormone-related peptide secretion. Vitamin D toxicity can again cause hypercalcemia. However, we would expect maybe some nausea, vomiting with it, or deranged kidney function, and none of that is suggested in this question as well. Okay, so if you have any questions about this, do pop them in the chat. But we'll go over the mechanism of this in the next slide. So non-small cell lung cancer is relatively more common. Squamous cell cancer is more centrally located. So this releases parathyroid hormone-related peptide, which can cause hypercalcemia. Some of the other features that it is associated with includes clubbing and HPOA, which is hypertrophic pulmonary osteoarthropathy. And I'll go over that in the next slide. So with hypercalcemia, we expect some vague symptoms. So maybe some nausea and vomiting, confusion, fatigue, constipation, bone pain as well. It ranges in severity and mild, moderate, and severe. And we can see some ECG changes like short QT or bradycardia. And it's managed primarily with IV rehydration. So we aim to give them 3 liters per 24 hours, but that varies from case to case depending on their other comorbidities as well. And in some other cases, you can consider bisphosphonates like zoledronic acid, but it's usually done after discussion with seniors. The next type of non-small cell lung cancer is adenocarcinoma, and these are tumors arising from bronchial glands. So these are mucin secreting cells. They are periphery located. So far, other two cancers, that the small cell and the squamous cell, were both central. So this is our first periphery located lung cancer. And it's the most common lung cancer found in non-smokers. And this is also associated with hypertrophic osteoarthropathy, which is essentially a triad of inflammation around the connective tissue around the bones, clubbing, and I forgot the third one. It was clubbing and tenderness over the joints and bones as well. This cancer is associated with releasing some procoagulants, so basically increasing clotting factors. So depending on where they are in the body, it can cause symptoms. So it can increase the risk of strokes, MI, limb ischemia, DVT, or PE as well. Okay, so the next cancer is mesothelioma, and it is a rare and aggressive tumor, and it commonly affects the pleura. So it's not a cancer in the lung itself, it's a cancer in the pleura. And as the name suggests, it originates from the mesothelial cells, which are essentially cells that form the visceral lining. It is commonly associated with asbestos exposure. So, in your history, you might have someone who was working in shipbuilding or mining, or involved in insulation work as well. It carries a latency period for about 20 to 40 years since exposure to the diagnosis. So, it might be that the person worked in one of those industries in their early 20s or 30s, and they can be diagnosed with this in their 80s as well. Smoking is not directly linked with malignant pleural mesothelioma. However, we know that smoking combined with asbestos exposure can increase the risk of lung cancer. Unfortunately, this carries a poor prognosis, and sometimes, because of its location in the pleura, it commonly presents with pleural effusion, and that is the initial finding in lots of patients. So you can do a pleural tap with the help of an ultrasound scan and analyze these cells, and it may show some atypical mesothelial cells. Okay, so next is case number 4. We've got a 62-year-old male with a history of smoking who's presented to ED with 3-day history of worsening facial swelling, headache, and shortness of breath. On examination, he has distended neck veins, raised JVP, and facial congestion. His oxygen saturation is 93% on room air, blood pressure is stable. He's increasingly tired, and he mentions that raising his arms over his head worsens his symptoms. A chest x-ray shows a right-sided lung mass. So which of the following is the most appropriate step in the management of this patient? Okay, so this is a mixed bag as well. So we've got people going for an urgent CT chest, starting high dose diuretics and steroids, and endotracheal intubation. Okay. So the correct answer here is performing an urgent CT chest. Okay. So can people put in a chat as to what they think is going on? What is this condition called? Any ideas are welcome. Just Okay, so question asks for the next management step. Isn't chest X-ray? Yeah, so chest CT chest is an investigation. It's not management, but in terms of what you would do next, in terms of managing this clinical situation, it can still come up as an investigation. Like an investigation might be the most important thing you want to do next. Okay, so just discussing the reasoning for this. Superior vena cava obstruction. Yes, that's the correct answer. So essentially, we've got someone who's presenting with symptoms and signs of superior vena cava obstruction. It's quite evident that when he raised his arms, the symptoms get worse. Okay, and we've got a chest X-ray. So far, we've got a chest X-ray that shows a right-sided lung mass. Just going over the options, so commencing IV antibiotics and admitting for admission wouldn't be appropriate in this case. We've not got any evidence of infection. Starting high-dose diuretics and steroids immediately might be useful in the long term, but not immediately. And the reason for that is, what is the diuretic going to do? It will maybe help with shortness of breath, or maybe offload his fluids. Or steroids might be given to help with inflammation, especially if you're suspecting cerebral edema. Okay, in this case, it's not addressing the main concern here, which is our suspicion of SVCO. And what we want to do is we want to get a CT chest to confirm that diagnosis, because until and unless we don't have that diagnosis, we can't offer definitive treatment, which will delay the treatment that he needs. So I hope that answers that question. And let me know if there's any other questions with that. Immediate endotracheal intubation wouldn't be appropriate in this scenario because he's clinically stable. His blood pressure is stable. There's nothing in the stem that's suggesting that he's got airway obstruction or reduced GCS. And initiate anticoagulation for suspected PE. Again, that is not appropriate because we don't know that whether it is PE or not. There's nothing in the history that's suggestive of that. So I hope that clears the question. And let me know if there's anything else with that. So SVCO is essentially caused due to a tumor that's compressing on the superior vena cava. So we know that the superior vena cava is a big vein that carries deoxygenated blood from your head, neck, and upper vessels to the right atrium. And it can be a medical emergency as well. So if there are any signs of airway obstruction, so if you hear any stridor, or if there are neurological symptoms that maybe suggest that there is some element of cerebral edema going on, then you want to get an urgent senior review or do a peri-arrest call. Pemberton sign is important. It commonly comes in exams. So raising the arms over the head causes facial congestion and swelling. Imaging, you can do a chest X-ray to look for any lung mass, and you can do a CT chest to find out more information about the lung mass or the compression of the SVC. The definitive management is relieving the obstruction. So that might be with the stent and treating the underlying cause. You can do a conservative trial with sitting up the patient or providing them with oxygen. And you can also treat them medically with diuretics and steroids. But these are more for symptom relief rather than addressing the underlying cause. Okay, so we've got our second last case for the day. So it's a 59-year-old male who presents with a history of smoking, unilateral shoulder pain, numbness and weakness in his right arm over the past few weeks. On examination, he has ptosis, meiosis, and anhidrosis on the right side of his face, and a CT chest reveals a mass in the lung. Based on this presentation, where is the tumor most likely located? Okay, so we've got a unanimous answer right up a pole in the apex, and that is the correct answer. Okay, so can someone tell me what type of tumor this is? So we've got a patient with unilateral shoulder pain and numbness and weakness in his arm, and he's essentially got Horner syndrome with it. Pankos tumor, yes, that's correct. So Pankos tumor is commonly associated with Horner syndrome, and that's mainly due to its location. So what is it? It is when the primary tumor is in the apex of the lung. Most of them are non-small cell lung cancer, and the symptoms result from the tumor compressing on the neurovascular bundle and usually results in sympathetic plexus compression, which causes Horner's. So you have your eyelid drooping, constriction of the pupils, and loss of sweat from that side of the face. And it can also present with some pain and weakness, as well as numbness in the upper limb, and that's because of invasion of the brachial plexus. So there are lots of structures in that area, and depending on whatever the tumor is compressing, people can have lots of different symptoms. So some of the other complications that are associated with lung cancer include recurrent laryngeal nerve compression. So patients might present with a hoarse voice, and you want to refer them to our ENT colleagues for advice. They can also present with dysphagia, and that can be caused due to esophageal compression as well. We know that our C3, 4, and 5 innervate the diaphragm, and if there is a compression of that nerve, it can cause paralysis of the hemidiaphragm, and it can cause the phrenic nerve palsy, so the weakness of the hemidiaphragm as well. In your examination, it can present with decreased chest expansion or an elevated hemidiaphragm in a chest X-ray that we can see in the chest X-ray below, where the right hemidiaphragm is elevated. Usually, patients can also present with pleural effusion and with cancer that's commonly exudative. Unfortunately, in today's session, we don't have time to go over the analysis of pleural fluids, but hopefully in our future sessions we'll be able to do that. But you can manage pleural effusion with either aspirating it for symptomatic relief, and if that's not helping, we can do a procedure called pleurodesis, which essentially aims to reduce the gap between the lung and the chest wall. And sometimes patients can present with pneumothorax as well. If the cancer starts being necrotic and going over the lung lining, then it can infiltrate into the pleura as well and cause pneumothorax. Okay, so in terms of metastasis, so we've got 4 common sites. So an abbreviation would be BLAB, so brain, liver, adrenals, and bones. With brain, people can present with seizures or any neurological deficits. We might want to do a CT head, look for any cerebral mets, any signs of cerebral edema. And depending on those, we can consider treating them with steroids and or radiotherapy to provide symptom relief. If people have bone pain, we try and manage it with analgesia. If it's not being managed with analgesia, then again, we can consider radiotherapy. Something to remember to not miss out would be spinal cord compression, and it is a medical emergency. So if the tumor is compressing on the spinal cord, then it can present with back pain, changes in sensation in the perianal area. People might have fecal incontinence, urinary retention. So if there are signs suggestive of that, you want to get an urgent MRI head, and not MRI head, sorry, MRI spine, and contact neurosurgery for advice. Okay, so this is our last case for the day. We've got a 58-year-old woman with a history of unexplained weight loss and cough. She undergoes a CT, which reveals a lesion in the central airway, which is the next most appropriate diagnostic procedure for confirming the diagnosis of lung cancer. Okay, so the majority have gone for bronchoscopy with transbronchial biopsy, and some have gone for video-assisted thoracoscopy. Right, okay. So the correct answer here is bronchoscopy, and the keyword from the question is that the mass is in the central airway. So just going over the options here. Open lung biopsy is an invasive procedure, so you want to avoid that unless we've tried the other options or the other options are not feasible. Video-assisted thoracoscopy as well as percutaneous needle biopsy, they are both methods useful for biopsying lesions in the peripheral part of the lungs. Because this is in the central airway, it's easier to go with a camera down through the throat and get a sample. Okay, whereas in the peripheries, that's not a feasible option. If we go to the center, it can cause lots of complications, which is why we want a percutaneous access via the peripheries, which is why we would go for those options. And pleural biopsy, again, this is a cancer in the airway, so a pleural biopsy would not be very helpful. In terms of your investigations for lung cancer, so often a chest x-ray is the first line, and then we can do a CT chest if our index of suspicion is high with a normal chest x-ray, or we've got a mass on the chest x-ray and we want to further characterize it. Once a mass is confirmed on CT, would this be typically very rigid or flexible? Oh, that's a good question. As far as I'm aware, it's usually flexible, if you mean the one with the central, with the bronchoscopy. But I think it might vary from case to case. I unfortunately don't have a definite answer, but as far as I'm aware, it's usually a flexible one. Okay. Coming back to staging, so once we have a lung mass confirmed, we want to do a staging CT, which includes liver, adrenals, lower neck to stage the extent of the cancer. Sometimes we might want to do a PET CT scan, and that includes injecting basically a radioactive sugar and seeing how the cells take that. Usually with the site of tumor, because the cells are rapidly growing, they have a higher uptake of the glucose and the cancer appears a bit glowy, essentially, on that CT scan. MRI is uncommon for staging, but may be used if necessary. In terms of your definitive diagnosis, it needs a biopsy. This is performed in secondary care. So for the central tumors, we usually go with a bronchoscopy. So inserting a camera down through the windpipe into the main bronchus and going further from there. We've got EBUS as well, which is essentially the same thing as bronchoscopy with an ultrasound scanner in the form of a small camera. And this helps locate the lymph nodes as well. So we might be able to aspirate a nearby lymph node for biopsy. For your peripheral tumors, we want to go through the peripheral route. So if you look at the image above here, the first one, so we can either do a percutaneous needle biopsy, so that's inserting a needle either through CT guidance or ultrasound, more commonly CT, to get a sample. We can also do VATS, which is video-assisted thoracoscopy. So this involves making some small incisions in the chest to pass a camera tube and take some samples. We can do an open lung biopsy as well, but again, that is invasive. So if we can make do with the other options, they are more preferred. If patients have pleural effusion, we can do an aspiration. We can do a pleural biopsy as well. So staging lung cancer is quite complex and there are lots of stages involved. At this stage, I wouldn't worry too much about each and every specific stage, but it's a good idea to have a knowledge about the staging systems. And it is relevant in the sense that staging affects management. So for your non-small cell lung cancer, TNM is a popular staging modality used. So T is the size of the tumor. So it ranges usually from 1 to 4. N is whether it's spread to the nearby lymph nodes, and M means whether it's spread to other distant parts of the body. You also have stage 1 to 4, depending on how severely the cancer has spread as well. So these are both for your non-small cell lung cancers. For the small cell lung cancers, it's staged as either limited disease or extensive disease. So limited disease might be that it's confined to a single lung, whereas extensive disease is when it spreads to different parts of the body. So management of lung cancer is complex, and you want to involve lots of different people. So it might be respiratory physicians, oncologists, surgeons, pathologists, radiologists, cancer nurses. Okay, so it varies from person to person. Just some points to consider before you want to treat someone is what is the stage of the disease, what type of the disease it is, what is the performance status of the person? So at home, are they usually fit and independent, or is it more of a person who's bedbound and not able to do their daily activities? That affects, that will give surgeons an idea of how well the person is for surgery. You might want to do some pulmonary function tests, advise patients for smoking cessation if they smoke, the age of the patient, as well as some cardiovascular risk factors as well. So these are things taken into account when discussing management for a patient with lung cancer. So if the disease, so just in terms of management, I'll start with non-small cells. So if it's early stages, because we know that non-small cell cancer divides relatively slower. If it's very early stages, we can consider surgery for curative intent. So there are lots of different types depending on how spread the cancer, how far the cancer has spread. So you might remove a small part of the lung, you might remove a segment of the lung or an entire lobe. So we've got 2 lobes on the left side, 3 lobes on the right. And in some cases, you might do a pneumonectomy, which is removing the entire lung. We can also do radio and chemotherapy before or after the surgery. And with non-small cell lung cancers, we also have lots of targeted therapies. So if patients have some specific mutations, we can treat them with that specific targeted immunotherapy. And the benefits with that is it carries less side effects because it's specific to that cancer cell. In terms of small cell lung cancer, so again, unfortunately, because this disease is usually quite, first of all, aggressive in terms of how fastly it spreads, and it's quite extensive at the time of presentation as well. So surgery is usually not used, but if there is a person who has very limited disease, it can be considered. But mainly for small cell lung cancer, chemotherapy is the main treatment. You can also consider radiotherapy for patients. You can also consider prophylactic intracranial irradiation to prevent brain mets. So small cell lung cancer is more commonly associated with brain mets. So we can consider some prophylactic radiation to prevent that. And with some patients, if the disease is far spread quite far, you can just consider a palliative approach. So that would include treating symptoms. So if they are obstructed in the bronchus, you can do stenting or external beam radiotherapy to help with symptoms of shortness of breath. You can do, if they have pleural effusion, we can aspirate it or drain it if it provides symptom relief. And you can treat symptoms. So if they are short of breath, if they have pain, we can offer anticipatory medications like opioids or counseling and supports as well. So in terms of supporting patients through this, when you're initially referring the patients for suspected cancer referral, it's good practice to explain to them that they are being referred under this pathway. Most of the patients do not have a diagnosis of cancer, so you can just reassure them of this, that at this stage we don't really know what exactly it is. Most of them are not cancers, but we just want to make sure that that is something we don't miss. Lung cancer specialist nurses are a fantastic point of contact for patients, and you can also signpost them to Macmillan Cancer Support and Cancer Research UK. Both of these organizations have lots of support, advice, leaflets if they want more information. If patients are for palliation, offer to discuss end of life with the person quite sensitively, and if possible, avoid leaving this discussion towards the end stage of the illness. And you can involve the community palliative team as well as the hospital palliative team for more support if needed, if patients have complex symptoms or you feel they are at the last stage of their life. So that's the end. If anyone has any questions, please pop them in the chat, and I've just put a feedback form in the chat as well. So if you can fill that, that would be very helpful. It will help us improve these sessions. If you have any ideas, if there's something we could improve, something you like, just let us know. Hope it was useful. Thank you. Thank you.